Thank you very much, Mr. Chairman, and many thanks to the Scientific Committee for the invitation. This is my disclosure. So, novel approaches to ovarian stimulation is a very broad subject that could easily cover the program of an entire Congress. Instead of that, I'm going to focus on two very important issues: the use of new protocols for LH suppression, which have the potential to replace GnRH analogs, and frozen embryo transfer, which refutes the everlasting dogma in IVF for prioritizing fresh embryo transfer, and for many is considered the new norm in IVF. So regarding new protocols for LH suppression, we of course talk about progestins. Progestin administration along the whole stimulation maintains the pituitary suppressed and prevents LH surge effectively. Obviously, the use of progestin implies that we have to freeze all embryos and transfer them in subsequent endometrial preparation cycles. The reason is that the endometrium will not be receptive in a fresh cycle due to the effect of the progestins. Recently, the Ovarian Stimulation Guideline Group issued a recommendation regarding progestin use, in which it was stated that the use of progestin for LH peak suppression is probably not recommended, and if applied, progestin can only be used in the context of non-transfer cycles. This recommendation, however, was conditional. And it was a conditional recommendation since the available data, although reassuring, they were very limited and did not include any RCTs. Today, many more studies on the use of progestins in ovarian stimulation for IVF have been published and have been summarized in 5 systematic reviews and meta-analyses, focusing on the probability of live birth, on the incidence of congenital malformation, on the effectiveness of progestins when applied in poor responders, on the probability of live birth, focusing whether the comparison arm was agonist or antagonist, and on the probability of pregnancy, taking into consideration whether the data available originated from randomized controlled trials or non-randomized controlled trials. The systematic review by Alexandru in 2020 showed no difference between progestin and GnRH antagonists regarding the probability of live birth ongoing pregnancy, either in women who use their own oocytes or in oocyte recipients. The same meta-analysis suggested that a higher probability of ongoing pregnancy live birth was present with the use of progestins when they were compared with GnRH agonists. The systematic review by Zolfaroli, published in 2020, suggested that a similar probability of congenital malformations is present when progestins are used for ovarian stimulation as compared to GnRH agonists. A subgroup analysis based on the type of progestin showed again similar incidence of congenital malformations between progestins and GnRH agonists. This was also the case when subgroup analysis was performed, differentiating between singleton and twin pregnancies. No difference in the incidence of low birth weight was also shown between progestins and GnRH agonists, as well as for the incidence of preterm birth. Application of progestin-primed ovarian stimulation protocols in poor ovarian responders was studied in the meta-analysis by Kai, published in 2021. These authors could not show a difference between progestin-primed ovarian stimulation protocols and various control protocols, such as Chinese minimal stimulation for IVF, antagonist protocol, short GnRH agonist protocol, and ultra-short GnRH agonist protocol regarding the probability of clinical pregnancy. Although no difference was seen in cycle cancellation rate between progestin-primed ovarian stimulation and various control protocols, some significant difference in favor of progestins were shown regarding the number of M2 oocytes, the number of embryos, and the number of high-quality embryos. These differences, as can easily be seen, are of debatable clinical significance. The meta-analysis by Kui, published in 2021, showed a similar probability of live birth between progestin-primed ovarian stimulation and various control protocols, both in randomized control trials and non-randomized control trials. However, meta-analysis of 2 RCTs suggested the presence of a lower probability of ovarian hyperstimulation syndrome with the use of progestin-primed ovarian stimulation protocols. No difference was shown regarding duration of ovarian stimulation between progestin-primed ovarian stimulation protocols and controls, both in RCTs and in non-RCTs. Regarding gonadotrophin consumption, although some difference were shown between progestins and controls in the non-randomized controlled trials, no difference could be shown when only randomized controlled trials were analyzed. Similarly, no difference in the number of cumulus oocyte complexes retrieved or metaphase 2 oocytes was shown in randomized controls and non-randomized controlled trials comparing progestin-primed ovarian stimulation protocols and controls. Although a difference was shown by analyzing randomized controlled trials regarding the number of embryos in favor of progestin-primed ovarian stimulation protocols, this difference of 0.35 embryos is of debatable clinical significance. The meta-analysis by ATA published in 2021 show no difference in duration of stimulation, gonadotrophin dose, number of cumulus oocyte complexes retrieved, and of metaphase 2 oocytes between progestins and GnRH antagonists. In the same meta-analysis published in Human Reproduction Update, no difference could be shown regarding the probability of pregnancy expressed as live birth ongoing pregnancy, or clinical pregnancy. No difference was also shown in miscarriage or multiple pregnancy between progestins and GnRH antagonists. Similarly to antagonists, the comparison between progestins and GnRH agonists show no difference in duration of stimulation, gonadotrophin dose, number of cumulus oocyte complexes retrieved, and number of metaphase 2 oocytes. This was also the case with the probability of live birth or live birth ongoing pregnancy and clinical pregnancy. Again, no differences in miscarriages or multiple pregnancy were shown between progestin and GnRH agonists. The meta-analysis by ATA offered also data on the comparison between two different progestins, methoxyprogesterone acetate and dydrogesterone, showing again no differences in duration of stimulation, gonadotrophin dose, number of cumulus oocyte complexes or M2 oocytes between these two progestins. Methoxyprogesterone acetate and dydrogesterone did not also differ in the probability of clinical pregnancy, miscarriage, or multiple pregnancy. Although certainly more randomized controlled trials are necessary to compare progestins to established late suppression protocols, based on the published literature, it appears that the use of progestins is of comparable efficacy and safety to these protocols. Moreover, the introduction of progestins in ovarian stimulation for IVF has allowed the development of new concepts that can take us a step further, even beyond progestin-primed ovarian stimulation. Such an example is late initiation of stimulation. Under this concept, FSH is initiated in the late follicular phase and no exogenous pituitary modulators for a late suppression are employed. The study by Chu and Fu, published in 2019, compared a late stimulation protocol with a short GnRH agonist protocol, the red and the green lines respectively. In the left charts is the progesterone level, and it is obvious that the progesterone level with the red line is much higher in the late stimulation protocol. This is due to the luteinization of the dominant follicle after its rupture. On the left chart are the LH levels, and it is easily seen that the increase in progesterone in the late stimulation protocol is paralleled by a decrease in the LH levels without the use of any exogenous pituitary modulator. Although the late follicular initiation protocol required significantly more days of stimulation and a higher dose of FSH, similar number of follicles greater than 11 mm were seen on the day of trigger, similar number of cumulus oocyte complexes were retrieved, and the same was true for metaphase 2 oocytes, 2PN embryos, and cleaved embryos. Eventually, the probability of clinical pregnancy per embryo transfer was similar between the late stimulation and the short GnRH agonist protocol. So certainly, progestin-primed ovarian stimulation protocols, but also late follicular initiation of stimulation can be considered in ovarian stimulation for in vitro fertilization when the freeze-all strategy is used. In the freeze-all approach, embryo transfer and luteal support, two of the necessary steps in conventional IVF, are omitted, and instead all embryos are frozen. The concept of freeze-all is not something terribly new. In fact, arguments in favor of the freeze-all approach precede the birth of the first IVF baby. It was said back in 1977 that the frozen storage of embryos would permit one or more embryos to be replaced into the mother's uterus during a menstrual cycle subsequent to that used for the collection of oocytes, and so utilize the natural sequence of hormones during the luteal phase in order to establish a pregnancy. And this was, of course, Patrick Steto and Bob Edwards. Whether freeze-all will become the new norm in IVF depends on answering these two very important questions regarding the mother. Does freeze-all increase the probability of pregnancy? And does freeze-all decrease the probability of ovarian hyperstimulation syndrome? So in the meta-analysis by Bosdo in 2019 with 3,400 patients, it was shown that the probability of live birth is increased in high responders compared to fresh transfer, and at the same time the probability of OHSS is significantly decreased. In the same meta-analysis, in normal responders, it was shown that the probability of live birth is maintained compared to the fresh embryo transfer, but at the same time the probability of OHSS is significantly again decreased. Following that meta-analysis, there is evidence published in Lancet by Vey, which suggests that even in normal responders, the freeze-all approach will result in a higher probability of live birth compared to the fresh embryo transfer, and of course a significant decrease in severe OHSS. No randomized controlled trials are available in poor responders comparing the freeze-all approach versus the fresh embryo transfer. However, data from retrospective studies suggest that the probability of pregnancy is similar between the two strategies. Overall, the probability of OHSS, which is not an issue in poor responders, is significantly decreased both in high responders and normal responders. At the same time, the probability of pregnancy is increased in high responders, is maintained or even increased in normal responders, and it appears to be similar between the freeze-all approach and the fresh embryo transfer in poor responders. These observations question the value of fresh embryo transfer practiced for so many years in vitro fertilization. What is even more important is that the replacement of ACG with GnRH agonist for triggering final oocyte maturation has the potential to result in a virtual elimination of OHSS. This was shown in the meta-analysis by Ioannidou, which analyzed 28 studies and 2,600 women. With the red arrow is the probability of severe OHSS in women who received agonist triggering and no luteal phase support, and this was 0 with a confidence interval of 0 to 0. Of course, we are all aware of sporadic cases in which women who received agonist triggering and no luteal phase support developed eventually severe OHSS. The problem in these case reports is that the authors did not provide information regarding the number of women who received GnRH agonist triggering and no luteal phase support but did not develop severe OHSS. This information was only provided by the study from Berkanoglu in 2019, which analyzed 5,600 patients who received agonist triggering and followed the freeze-all approach. The probability of severe OHSS in this cohort was 0 with a confidence interval of 0 to 0 in agreement with the meta-analysis by Ioannidou. Despite the obvious advantages of the freeze-all approach, a proportion of clinicians is hesitating to adopt it as a new norm in IVF, and this is based on concerns regarding safety beyond OHSS. And indeed, there are reports suggesting that hypertensive disorders of pregnancy, macrosomia, or post-term birth are increased in the freeze-all approach compared to the fresh embryo transfer. So, for instance, in the randomized controlled trial by Vey published in Lancet in 2019 with 1,600 patients, the probability of preeclampsia was 3 times higher in the freeze-all approach compared to the fresh embryo transfer. In that study, the protocols used for embryo endometrium synchronization was either the natural cycle in 62% of patients or the program cycle in the remaining patients. The difference between these two approaches for optimizing endometrium embryo synchronization is the presence or absence of corpus luteum. Apparently, in the program cycle, corpus luteum is absent. The importance of the presence or absence of corpus luteum during achievement of pregnancy in frozen embryo transfer cycles was shown in the study by Ginstrom, which analyzed approximately 8,000 cycles. In that study, cycles were analyzed depending on the type of preparation used to prepare endometrium, and it was clearly shown that the program cycle was associated with a much higher incidence of hypertensive disorders, of postterm birth, and macrosomia compared to the natural cycle and the stimulated cycle. And this was also confirmed in the study by Saito, which analyzed approximately 35,000 cycles. And in that study it was shown that the preparation of endometrium with hormonal replacement therapy was associated with a significant increase in the hypertensive disorders of pregnancy in the preterm delivery and in the postterm delivery compared to the natural cycle. So we are faced with two very important questions. Should we continue to honor GnRH analogs for suppressing premature late surge, or should we move to less costly, more patient-friendly and equally efficacious approaches? Should we at the same time continue the dogma of prioritizing fresh embryo transfer, or should we transfer the embryos produced in an optimal endometrium in a natural cycle with elimination of severe ovarian hyperstimulation syndrome? Both these questions signify that we live in an era of active changes in ovarian stimulation, changes that are always aiming in increasing the safety and efficacy of the treatments we offer to our patients. Thank you very much for your attention.